Grant, former Surgeon General Dr. Gina Benjamin, and California Surgeon General Dr. Nadine Burke-Harris for offering their expertise when it comes to the emotional and mental health of children. Many a time when people approach me about Homeland Security, it's about terrorism, technology, and aviation security. Many in Congress do not consider the intersection of public health and Homeland Security, but I'm thankful that my host, the Vice Chairwoman of the committee, Lauren Underwood, who's also a nurse, has been a voice for public health during her tenure on the committee. Vice Chair Underwood, who will be with us shortly, has reminded us often about people tending to forget our most vulnerable victims, our young victims, which are children. Just yesterday, we passed Congresswoman Underwood's bill in the House mandating a digital medical records for immigrant children who are coming across the border. As you know, we still have children that we don't know where they are because the paperwork and everything was just so egregious that they were lost. So we're happy to get it done. We'll see what happens when it gets over to the Senate. Acts of terror and natural disasters have long-lasting effect on the mental and emotional health of children. While we try to protect children at best, we can hope that these acts of terrorism and mitigate the damage from natural disasters. It's also appalling that the Trump administration implemented policies blatantly disregarding the health and well-being of children. Further policies created by the Trump administration ignore science and do not consider the trauma that occurs when children are detained or separated from their families. I've seen it firsthand. I've visited detention centers all across the country. This past August, I witnessed personally happiness turn to horror as children were separated from their families when ICE raided poultry plants in Mississippi on the first day of school. In the wake of these raids, I brought in leaders from the community to meet face-to-face to tell Acting Secretary about the damage done to the community. I'll be having a field hearing very shortly so the public can hear the devastating impact that those raids had on children. This conference series is another way we can get the word out and hold this administration accountable. I remain committed to doing just that, particularly when its policies hurt the most vulnerable among us, our children. I look forward to continuing this dialogue, and at this point, we want to ask Dr. Trent if she will come forward.
Good morning. Thank you for the opportunity to share a little bit with you this morning about my perspectives on the impact of bias and discrimination on children, really thinking about the needs of detained, separated, and unaccompanied minors. I'm currently, that one's not mine. I'm currently on the faculty at the Johns Hopkins School of Medicine in Baltimore, Maryland as a faculty member in pediatrics, nursing, and public health. I'm also the president of the Society for Adolescent Health and Medicine, and I am the chair of the section on adolescent health for the American Academy of Pediatrics. So for me, the premise is really that children, including adolescents, are the message that we send to a time that we cannot see, and that we have to act swiftly to ensure that the message we send is a decisive one. I am so proud to be the president of an organization that is stepping out front on the issues of inequity as well as racism and other forms of discrimination, to train our members, to work with the communities in which we're practicing to really have an effect. I'm also part of the American Academy of Pediatrics, and in our Blueprint for Children, we're very clear that one of our foci is really to address the issues that make some children more vulnerable than others. This year, I had the pleasure, it's been actually over several years, had the pleasure of really producing a statement from our Academy on the impact of racism on child and adolescent health, which came out over the summer, which has been well received in part because its release just happened to coincide with the El Paso shooting and some changes in policy in the government as it relates to how people wanted to handle detained youth. So one of the ways I like to think about discrimination, racism is just one of those, is these levels of racism. And there's one of my old professors, Kamara Jones, who's now in Atlanta, and taught us about this notion of the gardener's tale and has written about it extensively. And so to help people understand how racism works, you sort of have a gardener who has flowers, happens to love red roses, not so much pink roses, treats the red roses differently. The red roses soar, the yellow roses don't. It's a structural system, and as a result of it, the pink roses never quite attain that value. And so there's a structured system around that. Whereas personally mediated, which is what we're used to seeing, where people are attacked or bad words are said to them or people are harmed, are direct influences on the individual. So that would mean someone would come and just clip the tops, for example, off of those roses because they don't like pink roses at all. And so I think what we see now with regard to children are those two things coming together. We see us putting structures into place that impact their well-being, and because they're impacting largely concentrated focus groups of individuals right now, it does represent a form of discrimination. And because it's impacting children and families directly, and their experiences in our country, in our systems, have individual impacts, it's also personally mediated as well. And you see it, even the youngest children are really seeing these images. They're sort of how they think about these issues comes to fore. I think one of the things that I wanted to do was to really think about how it is that people around the country, because I represent people from across the United States, and both of these organizations have started to think about these issues. I'll tell you a little bit more about it later, but the real issue that emerged from our members of these organizations is that there's this climate of fear. So we have young people saying, these are teenagers. It makes me feel more fearful in the environment, even if we are citizens. Now everyone is afraid. So those are bystander effects. They're people who are U.S. citizens who are afraid. My mom doesn't want to watch the news anymore because there's a lot of negativity. It changes the way we feel because we're not safe anymore. So that's the impact on one's ability to parent a child. And then I think people are afraid of being deported. They're kind of terrorized because they feel that they leave their house to go somewhere, immigration might take them away. And so there's a culture of fear that's affecting many in the Latino community, and I think we just have to be aware of it because it does represent an ACE. So this is the CDC pyramid. CDC worked closely with the Kaiser Foundation to conduct research on the relationships of these exposures to health outcomes in the population. And this is really the framework that they're using so that there are these events that over time continue to build up, result in people engaging in health risk behaviors that ultimately affect their overall health and early death. So when we think about youth that we're talking about today, so when we think about detained or separated youth, there are really multiple pathways to adversity. The first is the adversity in the home country. So I'll share a little bit more about that with you as we move forward. But then there's also the issue of an unaccompanied minor. So the parents say, you have to go. It's not safe for you here, you have to go. So a minor may come across into the United States alone. Then you have forced separation in the United States, so where we would take a child from their parents, and the parent would be detained in one place and the child in another. And then there's adversity experiences in detention, and all of those three areas can result in adverse child or represent adverse childhood experiences for children. It's just important to note, so when you look at the data from the United States Customs and Border Patrol, you can actually see that most people coming in 2019 are actually families. So there are a lot of unaccompanied youth. You see them on the top row, but I've circled the number of people who are coming in families. So those are young people who are coming with an adult or another person in their family who could be a source of support for them, and that we're thinking about how we handle them. And if they're adults, they are separate. They are separated from that individual. I just want to be clear around our society's position around forced separation, because we are committed to really improving the physical and psychological health of adolescents and young adults. We really do condemn the segregation of separation of children and adolescents from their parents as a deterrent to migration. And the UN has been very clear that this is against the sort of human rights. While we have not necessarily signed on to that convention as a country, that it's really something that interferes with the rights of the child. That research really demonstrates that such policies are harmful to children, these targeted groups, adults as well. There's currently no legal provision for legal representation for minors. We would never have a child, a United States citizen, a child, go into court 3 years of age alone without an adult. We wouldn't have an adolescent 15 years of age going alone without another adult. And so that is what's happening here, and it also represents an adverse event for a child. We're also warehousing children and adolescents, which can be considered inhumane, and many of the health problems associated with detention are completely preventable. And so immigration policies, we feel, should not leverage the health and well-being of children and adolescents as a bargaining chip, and abusive practices cannot be weaponized in that context. Just to clarify, when we think of detention as adversity, we have to think about the research that's available. I'm a scientist, and so I try to pull upon the data. And I just pulled this one study because it's a systematic review in the interest of time, where they looked at over 2,000 titles and abstracts, 210 articles, and were able to identify articles with youth and families. And what they really saw is that all the children had at least one psychiatric disorder after being in detention. The overwhelming majority of them struggled with sleeping, eating problems, suicidal ideation, and self-harm. And the psychiatric disorders were 10 times more likely to occur subsequent to detention compared to those who were not detained. We also know a lot of detention, as these youth are experiencing, is very similar to detention that we see people with incarceration. And so when we look at it from that perspective, people who are detained for less than 1 month compared with no incarceration have an increased depression rate, almost 1.5-fold increased risk of depression. Those detained from 1 to 12 months have worse general health outcomes, and those detained over a year have adult functional limitations, over 3-fold risk, adult depressive symptoms, over a 4-fold risk, and suicidal thoughts, over 2-fold risk. For me, I focus on, many people like to talk about the babies and the younger children, which are critically important, but I know for a fact that some of my close colleagues, one of my co-authors from the policy statement, has already been here. I read her testimony, and she's talked to you about that. I want to spend just a little bit, because my focus is on teenagers. Oftentimes we see them as people who are completely able to manage things themselves, and that's not necessarily what we see. So I did survey. We have around 1,100 members, and this week I said, I want to get your perspectives from all over the country. We want to take our adolescent young people down to the Capitol so that you can hear what they have to say. So we have, and within 24 hours, I had a deluge of tons of data from all over the country, from our providers who are on the front lines taking care of these young people. There's research data, but there's also their clinical experiences. The first is, why do they come? Here's one. I was stabbed in school and only rescued because the staff found me, from a 14-year-old Guatemalan girl. A lot of it is about gang activity. I'll just look at one of these. My parents sent me to the United States because I've been threatened by gangs. They killed a schoolmate I was friends with. We used to walk and talk from school from the park. One day in the early morning, he was taken from his house and found dead the next day. The threats to my father and I continue, and since my father has family in different parts of El Salvador, they told him to send me away, or they would come for me. And that's when my father decided to send me to the United States. Or there's another one that talks about a very similar experience, but many friends in the home country being killed. People really feel the need to flee for their own safety. They also talk about their treatment upon arrival. Well, when I got there, it took my shoelaces, my belt, and all that stuff. The same thing we do for incarcerated individuals. They started calling me by my name and everything. They locked me in there with all the others, but there was no place to sleep. You just had to lie there on the floor. And since they caught me at like 1 a.m., I was thrown in jail around 3 a.m. I barely had slept. I was wearing a jacket, so I wrapped myself in it and sat in an armchair. It wasn't exactly an armchair. It was made of cement, but it became my bed for the night. He says, I almost couldn't sleep on it at all. And worst part is you couldn't even see it if it was day or night. Only when the food came, they'd give you a tiny piece of meat and a juice box. That was it. Sometimes a small burrito. That was all they'd give you. This person's been in the United States for 3 years, 16 years old. And then we look at their health and developmental needs. There's tons of issues. So when we look at doctors who created spaces for young people to receive refugee care, there's general stress around family reunification. There's housing stress, particularly if you go to a city that already has housing stress where property values are very high, and the people wind up migrating to other parts of the United States for work. Foster care issues. Some get placed into foster care, but then it's because it's unresolved conflict with people who are already here in the United States. Mental health issues I've already described here, but they range. They do describe this period of a honeymoon period after people sort of settle, but then you see suicide or thoughts and attempts begin to appear, and people start to have somatic complaints. Particularly, they describe in girls this aguadas, or having watery legs amongst female patients, where they just feel like they can't even stand on their own feet. Then there are issues around their academic level. People don't necessarily think about developmental issues in adolescence. They're in middle school and high school, but the reality is vocational attainment is a developmental milestone for teenagers. So we think about their school attendance, their ability to really participate in that process. Oftentimes, people have not appropriately identified their academic needs. They may not have been in school before. They may have developmental issues that have not been identified. They have trauma that impairs their results. We see a young 14-year-old girl who was assaulted when she was 8 years old, and her development literally academically stopped at that point. We have fear of participation in after-school activities and other developmentally supportive activities. There's a lot of employment pressure. There's a lack of access to health care. And many people now who have right to public benefits are actually dropping them. What we see is some people say they aren't seeing a lot of detainees because they're afraid to come into care. Others are seeing it all over the country. I think people talk a lot about the border, but this is one of our colleagues from Washington State who is really describing their experiences. Here's another example of a 15-year-old who immigrated from Guatemala seeking asylum from gang-related violence, who had type 2 diabetes. This patient was in DK, diabetic ketoacidosis, so life-threatening case of diabetes. The patient was then treated and then released with a very limited supply of insulin, i.e. not enough to take care of themselves, and wound up moving to another state for placement, and then was in DK again, so had another life-threatening issue while in our care. Then there are others, adolescents, who have autoimmune disease. This is another example of someone who's not given enough care and did not have enough medicine to care for themselves, and they have an inflammatory response resulting in a worse outcome for them. Sometimes people don't know who they can consent for significant procedures and have to go back and forth to try to figure out who's responsible. Then there's the whole issue of preventative services in detention. There's this call that now we're entering flu season. We cannot have people in mass housing and not immunize them against the flu. It is a public health problem if we don't take care of that. Then there are other issues I am a young women's health person, and when we think about things like basic hygiene, soap and showers, toothpaste, toothbrushes, but menstrual pads, one a day is not enough. At the first day of your cycle, it's not enough. And then access to really comprehensive reproductive health services, oftentimes which have had to go to court so people can get their rights. The other issue is bystander effects. I don't think people realize the impact that this is watching this happen. Latino children in the United States, other children of color in the United States, of general population. I had a child tell me that they woke up in the middle of the night with a nightmare because they thought that the police were coming to their house to arrest them. The family is not is African American, so we have people, young children, thinking about these things in their subconscious, whether they affect them or not. I would have thought he would think about other things to be at risk for him as an African American male, but he's worried about the context because he goes to a school where a lot of his friends are immigrants. I just encourage you to remember the things that allow young people to thrive. They have to be adaptable and flexible, have a sense of purpose, hope, be hopeful and for the future without worries and concerns, have life satisfaction, not be depressed, have to be overall healthy. But they also have to have a positive sense of ethnic identity. And it's hard to say how that will happen if they're now in a place where people despise them, given the rates of anti-immigrant sentiments in the United States. Right now, young people need heroes. They don't necessarily need people who hide behind masks or wear capes. They need grown-ups to stand up and become more powerful on their behalf. And so I'll just close and say I just hope that we can all work together to make sure that all the children in the United States, regardless of how they appear, have an opportunity to grow up and have healthy and happy lives, to be supported by their families, and that we don't allow bias and discrimination to enter into our policies and how we take care of them. Thank you.
Dr. Trent, thank you so much for that wonderful presentation. I'm Congresswoman Lauren Underwood. I'm the Vice Chair on the Homeland Security Committee, and I'm so delighted that we have this opportunity to hear from such great experts on the experience of childhood trauma, toxic stress, and the long-term development of the children that have been in our custody at the border. With the chairman, we have had a number of opportunities to visit the U.S.-Mexico border, border patrol stations, the CBP processing facilities, and have witnessed what you know will be traumatic experiences that will stay with these children and their families for the rest of their lives. And so during my short time in Congress, I'm a new member, a freshman, I have really taken on this challenge to try to right the wrongs that are being enacted in our name, which is what makes this so horrifying. You know, the administration comes in and says that the family separations have stopped, and then 1 or 2 weeks later, we go to the border and see them continue. You see the data, which suggests that fewer people are crossing the border, and yet people are remaining in custody for still untold amounts of time. And so these diversionary tactics, in my opinion, which suggests that maybe that there's a resolution in sight, that's what the administration would lead us to believe, in fact, is not the case, because we still have children being incarcerated in cages without access to proper medical care, medical screening, or interventions. And so on the committee, you know, we're so grateful that you all are willing to come and share the evidence. I'm a nurse, I have a public health degree, and, you know, strongly believe in data-driven, evidence-based approaches to policymaking. And for so long, many people either didn't value science and the research findings, or that data was not available. But in this circumstance, we have this wonderful combination of people who care, people in the majority who care, and we have long-standing, you know, pretty concrete scientific findings that suggest what the intervention should be. So the only missing part of this equation would be political will to get something done. And what I'm so proud of is that this House and this majority has that political will and capital. Just yesterday, we passed my bill, the U.S. Border Patrol Medical Screening Standards Act, to make sure that we don't have children that are continuing to die in federal custody, particularly as a result of preventable diseases. We've seen, even as recent as December 2018, where Jacqueline and Felipe, 2 children that were in custody at Border Patrol, died because they did not have prompt screening to identify their medical ailments when they entered into federal custody. That is unacceptable. It's bad enough to have, at this point, hundreds of thousands of kids who will have trauma and untold physical ailments as a result of their time in U.S. custody, but to now have this record of deaths is unacceptable. So I'd like to thank Dr. Trent. I'd like to thank Dr. Benjamin for joining us this morning. We certainly are eagerly awaiting your recommendations, you just might find them incorporated in some legislation. Well, that's my goal, at least. And the chairman's on board, so I think that's a good sign. Thank you again, and I'd like to bring up Dr. Regina Benjamin. No? Oh, well, hi, Dr. Burke. Dr. Burke is from, California Surgeon General. Oh, welcome. Thank you so much for joining us today. We're certainly looking forward to your comments and recommendations if you would join us. Thank you.
Thank you so much. Good morning. I'm Dr. Nadine Burke-Harris. I am a pediatrician, a toxic stress researcher, and the Surgeon General of California. And I would like to, I'm very grateful to be able to share how we can apply the science of toxic stress to child health policy, particularly at the border. So in July of this year, the National Academy of Sciences, Engineering, and Medicine Committee on Applying Neurobiological and Socio-Behavioral Sciences from Prenatal through Early Childhood Development with a health equity approach released the report Vibrant and Healthy Kids, Aligning Science, Practice, and Policy. And I was happy to be a member of that committee. And I want to highlight a few of the core concepts that the committee highlighted in the report, which I encourage everyone to download and read. So a couple of the core concepts that emerge from the last 2 decades of science on how our environment influences our biology. Right? So just as the invention of the microscope allowed us to move from miasma theory, which was that, illness was caused by foul airs, to germ theory, the notion that illness was caused by microbes, right? By allowing us to visualize these microbes. So advances in technology like functional MRIs, genomics, proteomics, metabolomics now allows us to understand how our environments interact and shape our biology. And what we understand is that biology-environment interactions impacts health and development, that major biological systems develop rapidly during pregnancy and early childhood, that the early caregiving environment is crucial for long-term development, that disparities in access to critical resources matter, that health conditions are the result of experiences across the life course, and that early interventions matter and are more cost-effective than later ones. Much of the research about the impact of early environments, and specifically early adversity, was brought to our awareness by the Adverse Childhood Experiences Study. This was a landmark study conducted by the CDC and Kaiser Permanente now more than 20 years ago, where they looked at the 10 categories of adverse childhood experiences, or ACEs, which include physical, emotional, and sexual abuse, physical and emotional neglect, or parental substance dependence, incarceration, mental illness, parental separation or divorce, or domestic violence. And we now recognize that those are what we call the 10 traditional ACEs. There are other social risk factors for health, like discrimination or poverty, which are also risk factors, but we refer to these as the ACEs because of their role in the Adverse Childhood Experiences study. And what that study told us was that, number one, adverse childhood experiences are common, right? 2/3 of the population have experienced at least one. 1 in 8 folks have experienced 4 or more. And that the more you have, the greater the risk to your health, right? In fact, if an individual has 4 or more adverse childhood experiences, and remember, that's 1 in 8 individuals. In California, it's actually 17.6% of our population. You have dramatically increased risk for 8 out of 10 of the leading causes of death in the United States. We're talking about double the risk for heart disease, more than double the risk for cancer, more than triple the risk for accidents, 3 times the risk for chronic lung disease, 2.5 times the risk for stroke, 11 times the risk for Alzheimer's, 1.5 times the risk of diabetes, 30 times the risk of suicide. So when we think about this and recognize that we have a large number of folks who are affected and the effects are significant, they're major health risks, this is what constitutes a public health crisis. And understanding, since the ACE study was published now 21 years ago, there has been a deep amount of science in understanding the mechanism of how this happens. And ultimately, it all boils down to the way our experiences activate our stress response. So you imagine you're walking in a forest and you see this guy, right? You see a bear. What happens in our brains and bodies? Our amygdala, right, which is our brain's fear center, sounds the alarm and activate. My amygdala was activated. Activates a release of stress hormones, including adrenaline and cortisol, that cause our heart to beat, right? Our hearts start to pound, our pupils dilate, our airways open up, so that we are ready to either fight that bear or run from the bear. And if you were to think about it, right, fighting a bear wouldn't seem like a good idea, would it? No, because bears are big and they have teeth and they have claws. And actually, one of the components of the stress response is that the prefrontal cortex, the part of the brain that's responsible for executive functioning and impulse control and judgment, gets turned way down, right? And instead, what gets turned up is something called the noradrenergic nucleus of the locus coeruleus, or as I like to call it, the part of the brain responsible for, I don't know karate, but I do know crazy, right? This is the within the brain stress response center, right? And it gets you amped up. Now, the less obvious thing that happens when we activate our stress response is that it also activates our immune response. Because if that bear gets his claws into you, you want your immune system to be primed to bring inflammation, to stabilize the wound so that you can live long enough to either beat that bear or get away. It's genius. It was evolved over millennia to save our lives from a mortal threat. But the problem is, what happens when that bear comes home every night? Or if you live in a country where there are bears on every corner. And when you flee that experience to try to find safety, there is a bear waiting for you on the border, right? What we see as a result of that is that we see overactivity of children's stress response. We see perpetuation of these impacts on the brain, the immune system, and our hormonal systems, which leads to a condition that is now called by the American Academy of Pediatrics the toxic stress response. And that is long-term changes to a child's developing structure and function of their developing brain, to their developing immune system, their developing hormonal systems, and even the way their DNA is read and transcribed, their epigenetic regulation. And while the ACE study looked at outcomes that happen in adulthood, things like heart disease and stroke and cancer, it turns out that the symptoms of toxic stress are evident as early as infancy. So in kids, what we see, as young as babies, we begin to see developmental delay, growth delay, failure to thrive, and sleep disruption. In school-age children, we can see symptoms of toxic stress in asthma, pneumonia, viral infection, atopic disease, which is eczema and other inflammatory diseases, learning difficulties, behavior problems. And then as kids get older, we see increased risk of metabolic problems like obesity and diabetes. And you heard Dr. Trent mention a case of a young immigrant who is in diabetic ketoacidosis. It is not just that he had diabetes and it was untreated. The experience of adversity biologically increases his risk of having a negative health outcome. We heard about these young immigrants with autoimmune disease. It is not just that they have autoimmune disease. If you have 2 or more adverse childhood experiences, your risk of autoimmune disease is double. The experiences of trauma and adversity augment the biological risks that individuals are facing. And throughout the life course, right, we see that for women who experienced adversity as children, they have increased risk of adverse prenatal and perinatal outcomes, everything from preeclampsia, high blood pressure that can be life-threatening, all the way to risk of fetal demise, right? And what we recognize is that these early signs and symptoms are just the bellwether. They're just the canary in the coal mine of the long-term health risks that individuals face when they develop this overactive stress response. But what we know from decades of research about toxic stress is that one of the critical aspects, if not the most critical aspect, is this component of buffering caregiving relationships. I want to highlight in that yellow box, the toxic stress response is along a spectrum of biological stress responses. You remember when I talked about seeing that bear in the woods, right? That was a normal biological response that was designed to save our lives from a mortal threat. That is the positive stress response. As the stressor becomes more severe, the biological risk becomes greater. But, and you'll see in this yellow box, homeostasis recovers through the buffering effect of a caring adult and other interventions. And an example of that tolerable stress is immigration and natural disasters. However, without that buffering caregiving relationship, when you take that critical ingredient away, that tolerable stress response can tip over to the toxic stress response, which is prolonged activation of the stress response in children that disrupts brain architecture and increases the risk of health disorders. So removing that buffer, taking children away from their caregivers, literally, biologically is a policy decision that we make that impacts their risk of lifelong disease and early death. So the buffering is a critical part, and this is actually something that the science shows us, right? That these buffering caregiving relationships physiologically, biologically, interrupt the biological stress response. What we see is that children who receive buffering have improved stress reactivity, improved autonomic functioning, that's this functioning of the nervous system, better sleep patterns, and better brain maturation, better maturation of the prefrontal cortex, which is responsible for executive functioning. And actually, that's measurable on MRI. When we use the highest standard of medical evidence, randomized controlled trial, what we see is that children who were randomized to high-quality nurturant caregiving showed normalization of the developmental trajectory of our white matter structures, of their white matter structures. We see protection, we see improvement of the functioning of the immune system and protection against infection risk. We see, and part of the reason that this happens is because the physiology, right, the way that nurturing care improves outcomes is partly through the release of hormones that counteract the stress response, like oxytocin, that inhibit the stress response, enhance bonding, protect against stress-induced cell death, have anti-inflammatory effects, enhance metabolic homeostasis or restoration of metabolic balance, and protect our vascular endothelium, the lining of our blood vessels. And that these changes actually go all the way down to our DNA, right? Researchers have found that nurturant caregiving was associated with epigenetic changes that protected against the impact of high stress. So what we know about buffering the toxic stress response, right, is that factors like sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships biologically buffer the toxic stress response. They reduce stress hormones, reduce inflammation, and enhance neuroplasticity, the ability of brain cells to form new connections in response to their experiences and environments. And the CDC tells us that safe, stable, and nurturing relationships and environments are critical for child health and development. But separating children from their caregivers flies in the face of this science, right? This is not about partisan politics. This is about basic biology. Well, we have seen what the Office of the Inspector General for Homeland Security found in these detention centers was exactly the opposite of the buffering factors, right? Serious overcrowding of unaccompanied minors and families. Escalation in security concerns. Children in 3 of the 5 Border Patrol facilities had no access to showers. Children with limited access to change of clothes. Limited access to children who weren't even receiving hot meals, right? These conditions only augment the stress response and increase the health risk that these children face. And the Inspector General for Health and Human Services found that the mental health services that were being provided in these centers did not meet the needs of the children. In fact, intense trauma was common among the children who entered the provider facilities, and that even for the children who weren't separated from their parents, right, which those children who were separated from their parents faced even greater trauma, but even the ones who weren't separated from their families found it traumatic to adapt to the facilities. And that the facilities reported that children who stayed longer had greater and greater and greater symptomatology. And that's just looking at the mental health symptomatology, right? Because we recognize that all components of buffering care are interrupted by the detention setting. What the Office of the Inspector General for Health and Human Services recommended, right, was to identify and disseminate evidence-based practices, right? Improve access to mental health care, and take reasonable steps to minimize the time that children remained in custody. So again, these are basic approaches that use the science and the biology of how our environments shape our health. But when we take a step back and look in a larger societal context, one of the things that the National Academy for Sciences, Engineering, and Medicine found in their recent report, Vibrant and Healthy Kids report, was that the health and well-being of children also depends not only on is profoundly impacted not only by the biological stress response, but also by the structural factors that alter the risk that that biological stress response will be activated, right? Things like, and you'll see in that middle section in the blue, right? We're talking about the biological, psychological, and socio-behavioral development, the things that actually happen in the body. But we recognize that these happen in a context of family cohesion, of social connection, of caregiver well-being. And that when we support these factors, right, that impacts a child's developing biology, right, and improves outcomes throughout the life course and into the next generation. Similarly, things like housing, living conditions, early care and education, and health care impact the ability of the family and the social structures to be able to provide those supports for children. And what we find is that fundamental programs like nutrition assistance, like Medicaid, like housing, that provide supports in each of these levels are critical to improving the health of our communities. And so when we see a rule like the public charge rule that impair young families' ability to get access to these services, we recognize that these policies, again, directly fly in the face of science and medicine, which is why the American Academy of Pediatrics, right, strongly voiced their opposition to the public charge rule, recognizing that this program, right, forces immigrant families into an impossible choice. Keep your family healthy, but risk being separated, or forego vital services so that your family can remain together. This is not what we want in our country. Finally, when we look at the recommendations of the national academies, they include intervening early, supporting caregivers, reforming the healthcare system to promote healthy development, creating supportive and stable early living conditions, maximizing the potential of early care and education to promote health outcomes, to implement initiatives across systems to support children's families and caregivers and community, and integrating these and coordinating resources across education, social services, criminal justice, healthcare, and making them available to translate the science. Finally, we recognize, right, that the science of our basic biology in terms of response to adversity is the same, whether we're talking about the traditional adverse childhood experiences, when we're talking about the experience of migration, or whether we're talking about natural disasters. All of the factors that promote the resilience are quite similar. These healing relationships, mental health services, safe housing, appropriate nutrition, appropriate sleep, physical activities, these are the same common factors that help to biologically buffer the stress response and promote healing and well-being in young children. Thank you.
Have a seat there. Good morning. I'm Regina Benjamin. I'm the 18th United States Surgeon General, so I'm glad to be back here, and I'm really pleased with the fact that you've had this hearing, because my whole time is about prevention, and this is all about prevention. And one of the things is to see how our government works is that the few people in this room can really affect the changes of numbers of lives for generations to come. So don't underestimate the power of those of us in this room. I'm really pleased to have the opportunity now to ask a few questions to our Surgeon General from California. This is the first time that we've had a state Surgeon General in the past several years. We used to, but Governor Newsom was wise, and you can see why I'm so proud of her, everything she just said. So congratulations on being our Surgeon General for California. So the other part I'd like to say is that the things that come out of this conversation that we're having can save the life of possibly the next or one of our future Surgeons General. So what we do really does affect the future generations. So I want to start with you and just kind of talk about, I heard you use the term epigenetics a lot. So I'm not sure if everyone knows what epigenetics means. Do you? If you do, I won't bother. But basically, just to clarify it, it's just things around our environment that affects each of us at a cellular level. And that cellular DNA level can be transferred to next generations. And so that really is long-term effects by what we see. So let me sit down with you and start by, is this on? Yeah, now it's on. There was a lot of information there, and it was great information, And how do we basically protect children currently who have been already exposed? And what can we do to help them while we move toward prevention? We want to prevent future children from having ACE effects, but what can we do now to help them minimize the effects that they've already gone through?
So I think one of the most important things that we can do is training of providers, of all child-serving, child-interacting providers. Because one of the things that we recognize, and we see even in this conversation about our immigration policies, right, that ignorance of the science about how early adversity impacts the developing brains and bodies of children, and what we can all do to make a difference is one of the biggest challenges we face. For example, one of the things that we see is that when children are, oftentimes when young people are in class, and perhaps they're acting up, perhaps they're having bad behavior, if they're demonstrating symptoms of toxic stress, right? Right now, there are, the norm is to respond with harsh and punitive practices, right? And rather than asking children what happened to you, many places across the country right now, there are folks asking children, what's wrong with you? And I believe that the opportunity that we have is for, so we recognize that biologically, we know how to buffer the toxic stress response. But what we need is this public health scale level of buffering. Every educator has the opportunity to be a source of buffering. Every auntie and uncle and caregiver. And so if we increase the cumulative dose of buffering through public education and training of every child care provider, right, that has the potential to be transformative in our society.
And as you know, public health is often underfunded, but that would be a place to start within the public health departments to try to get that going, I think.
That's right. And I will say, in California, California is I'm leading, I have the privilege of leading our efforts in California to move towards universal screening in primary care for adverse childhood experiences in both children and adults. So that's something that Governor Newsom actually allocated $40.8 million to actually reimburse primary care providers for screening for ACEs and responding with trauma-informed care.
So I want to ask you a couple of things about clinical things. So in these facilities, you know, both of you are pediatricians and family physicians. Continuity of care is important. Mm-hmm. Do these kids see the same clinician on a regular basis, or do they see a different person every time once they're in the facilities? In the detention facilities, do you know if?
In the detention facilities, so in the report that I read from the Inspector General for Homeland Security, continuity of care was an issue. That report was specifically looking at mental health care, but fragmentation as individuals are moved from one place to another, or as they are given the number of individuals and the level of overcrowding, the level of services seemed to be inadequate, and that was.
What about the size of the medical team? Are they? Well, we assume that they're overstaffed.
Yeah, I actually understaffed.
Understaffed.
Yes, that was actually one of the findings as well, as being understaffed, particularly in terms of mental health clinicians. I don't know for primary care providers.
And do you know where the kids, once they're released, where do they go? Who are they released in? Whose custody? I mean, do we have any idea? Have you seen any science behind that or numbers behind that?
I haven't seen the numbers behind where children are going. I think that there are a range of places where children are going, but I don't have those numbers in front of me.
Great. You talked a little bit, and I think we heard a little bit about some of the physical conditions, but in the previous poor medical care, do we ever see the kids talk about their previous medical care? Did they have it or did not have it? Or, for example, the kid who came with the insulin and his insulin was taken away from him. Did they have good care before, or do they come to us with things that need to be treated? Or are they already behind, I guess, in their care?
I don't know the answer to that from the reports that I've read, but the sense, I mean, certainly, and what we heard from Dr. Trent, right, is that children come with a range of pre-existing medical conditions that often are not addressed in a timely or effective way. I think, in addition, you know, one of the things I wanted to add about the care that these kids received is that we saw the news reports about children for whom Border Patrol and officers were explicitly instructed not to hold these children, not to comfort them when they cry, when literally that is fundamentally physiologically damaging. We recognize that holding children and comforting them can be as important as insulin or antibiotics. And so the whole, it seems like the whole range of children's health and well-being services is something that has been incredibly concerning.
You know, I'm from the Gulf Coast of Alabama, and hurricanes and natural disasters are a major part of our lives. So you mentioned it a few times. It was kind of alluded to. Tell me some of the effects of ACE on disasters.
So natural disasters are fundamentally scary, disruptive, and displacing experiences. And one of the things that we understand about the science of toxic stress, it's not just that individuals have individuals who have had an experience of childhood adversity may be at greater risk for physical, mental, or behavioral negative outcomes. But even for those, because of the change in the physiology, right, for many young people, they may show no symptomatology at all. But what we recognize and what the science shows is that there is what's called stress sensitization of the brain and body, right? Which means that even though you may be showing no symptoms now, because of some of the changes in the epigenetic regulation, as we talked about, that the brain and body becomes more sensitive to subsequent stressors, right? And then when you have a stressful or traumatic event, like a natural disaster, then that can tip an individual's physiology over into the development of frank disease. And this is why it's really important for us to do what the science shows is a best practice: early detection of ACEs and early intervention, so that we can buffer that biological response and reduce the risk that subsequent stressors will lead to disease.
Along those lines, we see an increase in intensity of these storms that are happening now, and all the science suggests they're going to get worse. And what specific steps do you think the government could do to add these buffering areas to be prepared? You know, we always do our get your preparedness, get your water, get your lights and your batteries. What could we do to prevent some of these adverse childhood effects?
So I think in the context of, I feel like there's so many things that immediately come to mind, and I know the topic of this conversation is not on climate, but there's a lot that we can do around that in terms of reducing the likelihood of major climate effects that lead to natural disaster. So that's really important. And I think about even in my own home state of California, where we had wildfires, right, which actually triggered tremendous trauma among the communities that were affected. But I think one of the pieces that are really important to recognize is, number one, recognizing that individuals who have had significant adversity are at increased risk of having negative health outcomes. We have the opportunity to provide in our emergency aid, not just the food and shelter, but also emergency psychological first aid, right? I think that's really critical to provide education to communities about how they can support themselves and each other around the psychological trauma and the physiological stress that we experience when there is a natural disaster.
I just remember seeing our kids, they've lost everything, and all of these people who mean well would send them their used things out of their attic, their used clothes, and they didn't have a place to stay, but they'd have boxes of used clothes and things, and the kids already lost everything. And psychologically, taking someone's hand-me-downs where you've lost everything else was a double trauma, particularly an adolescent. They just have those sort of things, the little things that happen when you have disasters. And I can only imagine that it's probably twice as much for an immigrant child.
Well, I think one of the things that our government can also do, especially in times of crisis, is send a clear message to victims of natural disasters that they are valued. And I think that our government has had a mixed track record, right, in what we, in how quickly we act, in the resources we provide, in what we communicate about for victims of natural disaster. And we recognize that these things matter. So exactly to your point.
I see our time has gone really, really fast. I didn't realize it would go that fast, but we do want to open it up for any questions from the audience if you guys have or comments.
Thank you. My question is, you mentioned that providers can offer these buffering effects, and every provider that's interacting with a child should be prepared to do so. In the circumstance of the children in U.S. custody, the majority of them don't have an opportunity to interact with a provider. The majority of them are interacting with law enforcement officials who do not, by their own admission, consider themselves to be providers and are very reluctant to engage at all in that way for, I think, a variety of reasons, one of which is that they are not trained to do so, they're not equipped to do so, and that is not what they signed up for. We know that, particularly for Border Patrol, that there is a significant morale challenge among their workforce, and adding a role of a provider in any sense would be something that I think would get significant pushback. And so do you have any comments on the responsibilities of just individuals, regardless of their clinical provider status, of offering these types of interventions to the children?
Yes. So I spoke specifically about providers, but I think that we can recognize that a public health approach to addressing the impacts of trauma and adversity has to be a cross-sector approach. And I would actually argue that Border Patrol law enforcement officials should be trained in trauma-informed care. I think that social determinants of health, and specifically toxic stress, is to the 21st century what infectious disease was to the 20th century, which is the notion that this underlying sense, when we understand this fundamental premise of how exposure to trauma and adversity fundamentally affects all of our health and well-being, then the purview of that knowledge is not just among medical and mental health providers. We all need to know that germs cause infection, and that's why we wash our hands, and that's why we cover our mouths when we cough, right? And I think the Border Patrol probably knows that they should wash their hands and cover their mouth when they cough. They should also know that the way they interact with the young people can increase or reduce their risk of disease. And that is in fact, I think, basic training that all of us, whether you're a healthcare provider or a law enforcement officer or a judge or an educator, should receive.
So I would agree with everything you said. I'd also say that as clinicians, particularly, we are constantly having to stay up to date on changing healthcare, health changing. I would engage the medical societies, particularly the larger ones like the American Medical Association of Pediatrics, AFP, to start to put this in their clinical guidelines and things to do, and they know them, and they all have, and that's what they're there to serve their members, particularly to start to make sure that continuing education is done. And we hold each other, as a profession, we hold ourselves responsible for continuing our education. So therefore, it's part of your licensure because you're self-governing, and that's the profession. The other thing I would say is that with Border Patrol and having been the United States Surgeon General, the clinicians that are in those facilities are public health officers. And we basically staff those borders. And as a public health officer, you are a member of a branch of the military that doesn't carry a gun, by the way. We shoot you with needles. So they can barely be instructed to do this. That's why they're officers, because we can send them in places that you can't send a civilian. And they should certainly have the Surgeon General should be pushing that out as part of what they should be doing. I think they are, but probably not enough. The other area is the community health centers. We require them to do a number of things. We can certainly start to put that into one of their measures that they do. And if they want to continue funding, they need to make sure they're doing these things. Any other questions, comments? Good.
With respect to trying to screen the younger children and adolescents who have been brought across the border, would you recommend a specific adverse childhood experiences type of child-focused screen so that caregivers, once these children come into the interior and have an electronic medical record, as has been now mandated, so that receiving communities or physicians or healthcare facilities could not only understand the trauma around the migration process, but pre-existing trauma for them? Do you think there's a checklist that would make it easier for healthcare providers?
I'm gonna let you answer that, but
Yes.
Dr. Trent, you can also chime in anytime.
Yes, in California for children, in our routine screening, we are using the PEARLS, the Pediatric Adversity and Related Life Events Screener.
Great. There was another hand someplace.
Thank you. Good morning. Erica Ninoy from Representative Meng's office. So I was a former health teacher in middle schools, and you know, I mean, I think this conference, for a real change to happen, this conversation has to hit our kitchen tables, our dinner tables, and so I'm wondering if you have any recommendations on, you know, can we change from the federal standpoint how communities are talking about this? Because like you alluded to, ACEs really hit communities in different ways disproportionately, and you know, how can we, you know, engage everyone in the discussion, and can we do that through federal policy?
To do that, so I will leave that federal policy question to you. I will say that that question of how do we bring this conversation to our dinner tables is one that I have been working very hard on for a very long time, and I literally wrote a book on the topic just for that particular reason. So I will say, check it out from the library. The Deepest Well: Healing the Long-Term Effects of Childhood Adversity, and it really kind of walks through a lot of the stuff, hopefully in a way that's kind of interesting and not too daunting. Because I do think that these conversations can happen in these places. And then on the federal level.
So behavioral change is the hardest thing to deal with, and we in my administration were often accused of being nanny state, telling people what to do in their house. But I do think it's important that we have a conversation and we start getting a campaign out. It's more of a raising awareness and getting people to talk amongst themselves, whether they agree with you or not, but have that conversation, begin to have that conversation. And we can be leaders in that, and especially the people when, the members, when you guys go back to your districts, you can raise those issues and have people start talking about them at their dinner tables.
One other thing I would add, there's also a wonderful film by Jamie Redford, the filmmaker, called Resilience, the Biology of Stress and the Science of Hope. So host a screening or a town hall.
I was just going to say that I think the kitchen table is really important, but one of the struggles that we have here in the United States is that parents oftentimes don't bring their kids in for care. And so the well visit is the sentinel thing that we use in pediatrics to check in with patients and families. From an American Academy of Pediatrics perspective, the racism statement, the poverty statement, we're committed to doing it. But I think that, and we're developing tools around racism, which is really innovative for, I think, our large organization. But I think people have to bring their children in. We'll get ready, but we have to see them in the office. And so one of the messages that we can send is around that. I think the other is around culturally and linguistically appropriate services. That is like the standard here in the United States. I think that the immigration issue poses a challenge for that. We have to have providers who can talk to these children. You can't tell them, if you don't speak their language, you have to have a third person. The person's on a screen from someplace else. They're not actually in the room with you. It's complex. And so I do think we have to think about that. And culture is not just language. It could be individuals who live here who are not culturally similar, but they have no understanding of how to communicate with families who are different from them. So I think those are some of the challenges to having people open up and say, we've had these bad things happen in our family. I think it's an issue of trust.
My next question was about the role of local public health. When we were on the border, we would hear some feedback saying that some of the border communities were less interested in assuming the additional responsibility for those in the federal custody. If there was an outbreak in a facility or something like that, that they didn't feel equipped, prepared, or really didn't feel responsible for offering that kind of local public health response to those federal facilities. That's in one instance. In my district, we have an ICE detention facility at our county sheriff station. They house ICE detainees. And so we've had, mumps outbreaks, that's just the latest one, but others, and our local public health has been called in to respond. And they have been willing to do so, albeit at a smaller scale, because it's just one with, a limited number of people. But just wondering, in the context of this conversation, what role does local public health have? How can we as federal officials be, and outside of just like properly funding local public health, right? Because that's an ongoing challenge. What can we be doing to work with them to get, discrete resources that they may need to help the federal officials, law enforcement officials, take care of these individuals in our custody?
So I would say that just funding local public health is a big thing. It is an ongoing thing. Unfortunately, it is ongoing, but it is a big thing. So I wouldn't say we need to throw money at it, but we would need to let them know that they could get reimbursed or something if they put it into it, because the local public health offices often don't have the money. It goes to the build the roads, it goes to things that get people reelected every day, and it doesn't get funded. So if an outbreak happened or if there was something that was needed, that the federal government would reimburse them for those things or reimburse their time. And we can put stuff in there. We have that in our federal response for disasters. We could do the same thing, but have it so that they know that they're not going to break the bank and not be able to treat regular stuff on a basis. That's one thing. The other, I think, is the local people in borders often feel afraid that if they agree, that they're going to get everybody. And so they're afraid of the overwhelmingness of it. And so we have to somehow let them know that they won't be there by themselves trying to take care of the entire problem. So. California may be a better place to answer that question.
Yeah, I mean, I think that we also in California, because we're a Medicaid expansion state, the safety net. I think that there is some strength to the safety net, right? And so when we're looking at, not that we don't have our own challenges in California, but I do think that strengthening our safety net and how we are providing support for vulnerable communities is a critical part of the equation.
And I have a different issue. I pretend I'm sitting out there asking us. So I live in Alabama, and we did not expand Medicaid. And you bring up these type of issues, and we've been trying to figure out a way to make it our issue other than their issue. People tend to look at it as another problem, not in my suburban area. And if you can figure out a way how to make it theirs, because it is theirs, but it's hard to make it a priority when it's seen as somebody else's problem, not mine. That's a question I don't have an answer to.
It's something that, speaking kind of outside of the immigration context, but particularly focusing on adverse childhood experiences and toxic stress, I think one of the reasons why the adverse childhood experiences study was so powerful was that it was conducted in among a population that was 70% Caucasian and 70% college educated. I mean, I can tell you that I was literally at an event on Monday where it was a philanthropic. I was at an event for a philanthropic organization where the board members, their minimum contribution is $250,000 a year. And 2 of the board members came up to me and shared their own stories of very high ACEs. This is not a them issue. I think that one of the powerful things, which is actually what makes me feel so hopeful about our ability to address it in a real systematic way, is that I don't think that there's any one of us who is more than 1 degree of separation from someone who has experienced significant ACEs, including probably every member of Congress, right? When we're talking about 2/3 of Americans, we're not talking about them, we're talking about us. And that, for me, is the hope, because I think that when we look at solving these issues in terms of, and also, driving down our healthcare costs. But when we look at the association between ACEs and having a heart attack or having a stroke or having Alzheimer's, right? This is not some abstract thing that we're only talking about, kids in a detention center or in a low-income neighborhood. And so advancing the science and advancing practice to reduce the impact of toxic stress, I think, is it has to be a national priority.
One more question.
This question is directed to both of you, and thank you so much for the wisdom that you have imparted to us. From a racism perspective also, Dr. Trent, do you have recommendations specifically for girls of color who have been really identified as being victims of community racism, of institutional racism, school in particular, and how we can support them better with respect to this type of adversity, which really isn't, pigeonholed as an adversity, and yet it seems to be quite across the board.
Well, I'm happy to share. This is actually one of the things that I'm really, really, really incredibly excited about in terms of the science of ACEs and toxic stress. Because while we recognize that discrimination, racism are not among the traditional ACEs, they are risk factors for toxic stress. And our advancement in the our ability to measure the biological impacts of toxic stress is now beginning to show us, right, that the cumulative dose of these adverse experiences um, profoundly impact health. And in terms of recommendations for girls of color, so there are, so number one, I think when we talk about those safe, stable, nurturing relationships and environments, those nurturing connections, and particularly from individuals that they can relate to, right? That trusted, caring adult, and we heard from Dr. Trent the importance of the cultural concordance between our young people so that people can say, you know what, wow, this person looks like me, and maybe they know a little bit about what I'm experiencing. For myself, one of the most joyful things about opening my medical practice in a low-income community, primarily African-American community in San Francisco, is that so many of my patients would walk in and be like, "You're the doctor?" And I'm like, "Yeah." And it was wonderful. That mentorship, I think, is critically important, but it's not enough. And I want to be clear that when we talk about these systems, if we're talking about truly improving health outcomes, right, then it has to include that one-on-one mentorship, that connection, those safe, stable, and nurturing relationships and environments. But this is the reason why a public health approach is so important, with training for every individual, from a police officer to an educator to a primary care clinician, and increasing the cumulative and society-wide doses of buffering, because this is something that our basic biology shows us that every child needs. And particularly for vulnerable populations, we recognize there are ways that we can do it to be more effective that are really, really important. And I also want to add, when we talk about sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships, I'll just very briefly share an experience that I had at the Baby Child Health Center, where we actually created a pilot program for young women, all of whom were young women of color, who had experienced significant ACEs. And we did mindfulness, and we did yoga, and we did movement, and particularly mental health. I think sometimes in communities of color, we shy away from mental health. And I did it with them. So they also had that mentorship. And to see the outcomes of these young women after going through this program, it was absolutely transformative.
Yeah, she really said it very well. One of the things I push is the physical fitness, walking, and one of the walking things, and there were these two young ladies who started this group called Girl Trek. And Girl Trek started with two young African-American girls that were doing part of the Surgeon General's walk. And Girl Trek is now up to over 1 million members. And basically we say you walked through out of slavery with the Underground Railroad, we walked through civil rights, and now we can walk for our health. And part of that health is with affirmations, doing the things you just described. Every day they're getting together and walking with friends, and there's a spiritual component, and it's basically showing you how strong you are and how strong African American women have been throughout history, and you are too. So those sorts of things just affirms what you're saying, does.
I'll just add that I think your question is really important, because we see it play out in the reproductive outcomes for women. So Michael Liu and Neil Halfon, who've done a lot of work on the life course from the Maternal Child Health Bureau, have really demonstrated that there are these issues that press down on women, particularly women of color, but particularly African American women, that affects their reproductive potential over time. And it's this toxicness that they're carrying in their communities. Strength is one thing, but I think women of color also need support. But there's a woman, her name is Janie Ward. She is Dr. Janie Ward at Simmons College in Massachusetts, who has done a lot of work in this area from an education lens. And we worked with her in terms of developing how we thought about strategies that we could give to pediatricians to tell young people. And one in the office is this notion of reading it, naming it, opposing it, and replacing it. So making sure that they read the scenario right. Is it racism, or is it you, or is it something else? And then to name what that thing is, right? And then to help them oppose it in a constructive way. I think that's the challenge. I think young people are trying to oppose things without adults. They need scaffolding to do that. And then we have to provide opportunities to replace those things. And I think this is a great example that she's given to young women. She's helping them replace it with this positivity and mentoring and, I want to be in the group. So those are all the kinds of things that I think that young women need. There's a lot of literature where people have talked about, for example, in particular in African American women, that we are not a protected class of people. We're probably the least protected class of American citizens. I will also say that it's going to be very difficult to protect women if we don't also protect our boys. I think the relationships, particularly as we see young women move into adolescence, their relationships with significant others, particularly those in heterosexual relationships, become very complex. And I think that if we also are not working with our young men, their interaction with young women can be quite toxic. So I think we have a lot of work to do, but helping them figure out what that thing is, I think is, and having insight around it is the critical piece to helping young women move forward in a positive way.
Thank you so much, and thank you, Congresswoman. We expect you to just go solve all these problems for us. And thank you, Dr. Trent and Dr. Burke-Harris, for a very interesting conversation that we have to continue. Thank you.